Hello, Life University. Dr. Gilles Lamarche, Vice President of University Advancement and your Assembly Coordinator. Welcome to Week 4 Assembly of the Spring 2020 quarter. And obviously, you're not on campus. Yes, we are missing you. We wish you were here. And certainly, I wish you were here to get to meet your Assembly Speaker and get to interact with him live. But I promise you that we will get him on campus as soon as we can. It is my great pleasure to introduce this gentleman. He hails from Victoria, British Columbia, Canada. He has been a friend for way more than a decade. But what I admire about this gentleman is his steadfast commitment to bringing the truth forward to chiropractic. And so, students, please welcome Dr. James Chestnut. James, thanks for joining me today.
Gilles, do you know that it's been more than 2 decades?
Really, huh? It's been more than 2 decades that I taught you how to iron a pair of pants in Australia?
Yeah, well, we met even before that, but yeah, it's and you know, sadly, I seem to have aged faster during those years than you have. You look the exact same. Oh dear. Anyway, I'm kind of like Benjamin Button in reverse here.
Well, anyway, I'm glad to have you, and I'm glad that you were willing to address our students live. And unfortunately, because we are currently online, we're doing it on Zoom, and they're going to get to watch this recording. And one thing, probably the most important things I wanted you to share with our students is really relates about the evidence. To share with our students the evidence that relates to the art, the science, and the philosophy of chiropractic, the science around subluxation, the science around the adjustment, so that they can have an even higher level of confidence that they made, number one, the right choice to become a chiropractor, number two, the right choice to come to Life University, and number three, that they will make the right choice to continue to expand their knowledge, their art, their science, and their philosophy. That's really what I'd like you to share with our students today.
Okay, well, obviously something initiated the initial desire to become a chiropractor, and you and I both know we've been through school, and we've both been involved on the educational side of things for a long time, and I think one of the biggest challenges is to, as a student at least, and I'll address it because this is a student audience, is just to maintain that enthusiasm that you had when you first walked in. Now, I would just say that the people who do really well in chiropractic and in life are the ones whose enthusiasm builds through time, not wanes. And so, but you have to understand that that's up to you. And what you're going to get excited about, I understand, might not be studying, histology late at night as you're going through your program. But if you can always relate what you're doing to being a better doctor and to being able to serve your patients at a higher level, and being a better expert in your product and services, then you're going to be able to categorize some things that I need to do to get my license, and that are just some basic knowledge that I need to have. I may not think I'll ever use it, and I might not, but it doesn't matter. It's part of the program. I'm not changing the program. I'm going to get it done. I'm going to, do it. And then the other part, which is to say, this is the stuff that I know is going to for sure translate into making me a better doctor. This is the stuff I need to be a doctor. This is the stuff that I'm going to be able to use to make myself an excellent doctor, clinical excellence, get the best outcomes, have the best practice possible. And when you're able to divide those things up and then really, suck your enthusiasm and positive attitude out of the things that are going to make you a better doctor, and that allows you to deal with the task. And just like when you get in practice and in life, and as a father, Gilles, or anything in life, there's always the things that we have to do. We don't always put them on the, in the category of, I just can't wait to do the dishes today, or I just can't wait to change that diaper, or, I can't wait to deal with whatever issues that we're going to deal with in practice or in life. But there's enough things in your life that if you focus on those things, and that's what you attend to in terms of to get energized and inspired, then you can have a blast at chiropractic college, and you can get the stuff done that you need to, and then you can get, really focus on the stuff that you want to do well in practice. So the one thing I would say to everybody is use that time that you have at chiropractic college to gain the highest level of expertise and scientific and sort of logical certainty, philosophical or logical certainty that you can, so that when you step into practice, the one thing that will never waver is your understanding that chiropractic is an evidence-based intervention, which is uniquely valuable to the citizens of whatever community you're going to live in. That's the thing that you need to build in chiropractic college, is that basic scientific certainty and the understanding of the philosophy too, which we'll talk about, or the paradigm. But that's what you really want. You can't get clinical experience when you're in chiropractic college. So that's going to come later no matter what. But what the one thing is that's going to determine whether or not you're successful and whether or not you have the energy and the passion required to get that clinical excellence is the fact that when you step outside, when you graduate, that you are never going to be shaken the rest of your career with anything regarding any doubt about whether or not chiropractic is worth paying for. If it's something that has unique value in terms of, when people get, it's a win-win exchange when people pay you for that chiropractic adjustment. And that's something I think you have to start with when you get out the door. And too few do, in my opinion. And so, but that is a personal responsibility issue. I know that students, when you get into professional school, now I have a sort of, I guess, a unique experience that I went to graduate school and did a graduate degree in science before I went to chiropractic college. And that really helped me to understand that when I entered professional school, like a chiropractic college, I'm no longer a kid. I'm not waiting to get spoon-fed. I am personally responsible now about the quality of education I receive. And I think that's one of the most important transitions that you can make, is that you've just got to grow up and understand that if you're complaining about something, it's because look in the mirror, because there's always something to complain about wherever you go, but there's always something great to experience as well. So when you become a chiropractic student, you have to immediately start looking at yourself as a doctor, and you have to immediately start asking yourself the right questions, which are, what do I need to learn and do and believe and think and act like in order to be successful? And I think that's really important, because I think sometimes people wait a couple of years or maybe even more, even before they start, sometimes until they get into clinic, and sometimes not even yet, and they still see themselves as a student and as a kid almost. And I'm saying
that is superbly great advice. And to take a piece of what you said, if I may, my mentor said, you've got to develop faith, confidence, and belief in your product, your service, and your ideas. He said, you say FCB and PSI. And what he meant by that, which is, related to what Dr. James just said, that when you develop certainty that's based on fact, on scientific fact, that in itself will inspire you. So I love that point, James. And
it's interesting because, and again, I'm not that much younger than you, a decade or so younger than you, I guess. But I'm a lot younger than you in chiropractic, because I was doing other things before I got into chiropractic college. And one of the things that I see, and you correct me if I'm wrong, but is that this idea of faith and belief now in this era of evidence-based, people don't understand it properly. And you just did something very important there. And you said faith, confidence, and belief, but what you need to have is scientific certainty.
In your products,
for you,
ideas,
they're indissoluble. They're the same thing. But for many of these students nowadays, it's almost an insult to think about what they're doing, that they need faith in it, or they need to have a belief in it. What they want, right? And I agree with it. And I'm part of that generation, really, is they want solid evidence to be able to understand themselves, because for them, certainty doesn't come from faith and belief. Certainty in healthcare comes from evidence. And so what happens sometimes is, and this is one of the great tragedies, is that too often these students don't really get the information they need about the level of evidence regarding the effectiveness and cost effectiveness and safety of chiropractic adjustment on its own, or as importantly, in comparison to the other alternatives that are available for people who are having spinal issues. And so I think that's a really important thing that and I think that's one of the reasons why I resonate with students, and chiropractors, is because what I'm saying is that What you need is evidence-based certainty.
Absolutely
Now,
agree.
now, in your generation, that's faith, confidence, and belief. It's the same thing, but we have an enormous amount, we have an enormous amount of evidence now, which is available to us, which wasn't necessarily available to your generation. And so I think that's one of the differences. And the other one is, I think also that faith, confidence, and belief is almost seen as in opposition to evidence-based care.
Yeah, and that's not what my mentor even said. So
I know.
faith, confidence, and belief is not just, it's not esoteric. It's actually when you have the scientific certainty, then it's easy to have faith, constant belief
Correct.
in the product, service, and ideas.
Correct.
And I know that's what you bring to the table all the time. That's why I always love listening to you, and I knew our students would love it when you get into sharing with them some of the science that actually shows the value of detecting subluxation and correcting subluxation, that's going to instill that level of confidence in who they are and who they are choosing to become.
Right. And I think one of the interesting things is that, so I think what happens is that we have this academic knowledge that we can gain. We can learn the science, we can read the studies, and all that's super important. I mean, it's me talking. I think that's the core of everything. You cannot be a good chiropractor unless you're an expert in your product and services. But that's not expert in delivering it. That's an expert in understanding why you should deliver it. And so what happens is you build this academic knowledge about the evidence, but at some point you have to take that academic knowledge and you have to translate it into a clinical delivery. And that's where the faith, confidence, and belief comes in. In other words, you have this knowledge and certainty, right, on paper, but when you're going to apply that to people, you have to have a level of confidence, right, that what you learned on paper is going to manifest itself in terms of clinical excellence and patient outcomes. And I think that's that sort of transition from being, learning the knowledge base and then making it practical, and so one of the things I like to say to chiropractors is there's a couple things I think every chiropractic student should learn in school. And, I can't wait to get down there and talk about it and stuff. But one of the things is you have to know your history a little bit. You have to know a little bit about the history of chiropractic in terms of its relationship to allopathy and the medical sort of paradigm. Because if you don't understand that, then you wouldn't really understand why there's still such an amazingly obvious bias against chiropractic, not only in the peer-reviewed literature, but just in terms of compensation from third-party payers, from policies, government policies, and everybody understands, right? There's an amazing bias against chiropractic, and if you're not careful as a student, even as a practitioner, you can actually start to believe that bias was earned because chiropractors somehow didn't have evidence or weren't getting outcomes or somehow were less scientific than other practitioners. But the truth is that we have always had an equal or a better level of evidence, but we haven't always educated everybody else properly about it. So there's a couple of things that are really important in terms of the history, and I'll just go over it really quickly if that's okay, about just some things that I think everyone should know. So the first thing every chiropractor should know is that you have to understand that it started, let's just go back and let's just go back to the 1978, 1979 New Zealand inquiry, right? So for those of you students who don't know what this was, is that basically in New Zealand, which has a socialized healthcare system like Canada and the rest of the world, other than the US, is that the medical doctors started to see that chiropractors were gaining not just reimbursement because they were getting paid as part of the socialized healthcare system, but they were getting the thing that's more threatening. Now, I'm not saying it's threatening to every individual medical doctor. There are many great ones. Don't get me wrong. But what I'm saying is a medical association or a pharmaceutical complex, pharmaceutical industrial complex, whatever, that makes money from selling pain pills. I mean, we are a threat. The fact that we're effective, we are a threat. We're competition. And so just be realistic about it. We are, in fact, competition. So what happened was the medical associations in New Zealand, and this is not unique to New Zealand, But the Medical Association of New Zealand started to complain that chiropractors were getting reimbursed. And what happened was many, many more patients stopped going to a medical doctor to get, which was essentially useless care for low back pain problems. It wasn't all about low back, but mostly. And they started going to chiropractors. So it wasn't just the fact that chiropractors were making a living, because they were making a living cash. It's that they were gaining cultural authority. And that is the single greatest threat to any monopoly, right? Is that if we start to gain cultural authority, so if you could just imagine for a second, if you might, that there were no financial barriers to going to see a chiropractor, that the playing field was actually even and fair and just and evidence-based, so that any patient anywhere that could go see a medical doctor could also go see a chiropractor if they chose. And ask yourself what would happen, right, to the number of people who started going to see chiropractors and the number of people who would decide to go to a medical doctor or a physiotherapist to get modalities. You know what I mean? And the truth is, we know this from evidence that everywhere that we've increased coverage for chiropractic usage has skyrocketed, right?
Because
And
chiropractors get results. I mean, we have a high satisfaction ratio.
Of course, the only reason our offices are not full is because of the financial barriers. I mean, it's obvious. Anyway, so what happened was the medical doctors and the medical association said, not only are they getting busy, right, but they're actually gaining cultural authority. And when the government pays for their services, the government is endorsing them as real doctors and giving them, you know, like this authority, and we can't have it. So we got to get rid of any reimbursement in the healthcare system for chiropractors. So they had this major inquiry in New Zealand. And what they did, chiropractors, it's unprecedented. Chiropractors open up their offices and says, you can come in undercover. You don't have to announce. You can come in and check out our offices. It was incredible. No healthcare profession has ever been, you know, so open, right? Transparent. So anyway, this commission, the findings of the commission at the end were chiropractic has great results. They have an area of specialization which does not exist in the medical profession, and they should be fully covered. They should be reimbursed. So that was the start of it, right? Then shortly after that, the Wilkes case occurred, basically 87 to 90, right? Because there was the last appeal was in 90. So then, by the way, after that New Zealand inquiry, you know, chiropractic usage started increasing everywhere because the news got out. And during that inquiry, they also looked into things in the United States and Canada and Australia. And so now all of a sudden, though, but then Chester Wilkes basically decided to sue the AMA, right? Because the AMA had an organized conspiracy to try to wipe out chiropractic as competition. And what the Medical Association did, the AMA did, and the hospital associations, everyone else got behind them, was they decided to have a patient care defense, which meaning what they said was, we're not trying to wipe out competition. We're just trying to protect the public against chiropractors because chiropractors are dangerous. They're not scientific. They're quacks. And what they do doesn't work. We're just trying to save people from being injured and from wasting money. So this was the defense they tried to put forward. Well, what happened in the court case was all the documents came out, right? There was actually literally somebody who went undercover, right? And testify because they worked for the medical association. They handed over documents and everything else. So we found out that the American Medical Association was lying. They were writing like fake documents to Reader's Digest and Mothering Magazine. They were telling medical doctors what to say if a patient came in and said they were getting good results with the chiropractor. To immediately say it was placebo and dangerous. They were putting packets in medical students' lockers about how to deal and train them to think of chiropractic as quackery. I mean, they lost. Like a couple of chiropractors beat the AMA. It's unheard of, right? With the most money in the history of, you know, any sort of group. You know, I always tell people in the 1930s, the second largest amount of money being spent on lobbying the United States Congress was, I think $100,000. The first amount was $1 million. Guess who was doing that? Guess who was spending that much money?
Pharmaceuticals.
AMA.
AMA. Whoa.
Guess where the AMA got their money?
Pharmaceuticals.
Obviously, where they get it now, pharmaceuticals. So it's been an enormous amount of lobbying, as we know. So anyway, the AMA tried to appeal the case, and they lost the appeal, right? And then they tried to appeal it again. And the Supreme Court of the United States said, we're not even going to hear your appeal. It's that bad. So so that's 79, now we're at 87. In 1990, a study by a guy by the name of Mead, M-E-A-D-E, came out. The Mead study came out in Great Britain. And what they did in the Mead study was one of the first times they actually did a direct comparison between chiropractic care and basically outpatient care in a hospital for people with low back problems. First time it was done. And what they found, well, one of the first, the first one that got published and was published in the newspapers all throughout the United Kingdom. So what they found out was people who went to a chiropractor spent less money, got better quicker, and stayed better longer than if they did what everybody else was telling them to do for decades and telling them not to go to a chiropractor. This shook the world. It shook the world. I was lecturing in London a couple of years ago, and I was telling people, going over just kind of this story, and I had a gentleman put up his hand, and he was probably in his late 60s, maybe early 70s, still going to seminars, which I think is amazing for chiropractors, paying his own bill, no pharmaceutical company paying. That's what I love about chiropractors. They pay for their own educations always throughout their careers. It's admirable, not mentioned enough. Anyway, this guy says, I remember when that Mead study came out and it got published in the paper. He said, I forget the exact number. He said, I had 82 new patients the next week. I said, well, that seems pretty good. How many would you normally have? He said, I'd be lucky if I had 2. And I said, why? What happened? Did you ask people why they're coming in? They said, yeah. When they saw that chiropractic had been studied, right, by researchers, and it was actually done in a hospital setting, and got published in the front page or the third page, whatever it was, of the Sunday, the London Times, whatever it was. He said it made us legitimate. And they finally felt like they had permission to go to a chiropractor, which they'd wanted to do for a long time, because the medical care obviously wasn't working, because it doesn't work for low back problems. And so he just said it opened it up because it was for the first time people saw chiropractic as being scientific.
And I've said for the last couple of years, one of my lines when I'm speaking is to chiropractors is for them to remember that science has become the currency of cultural authority.
Correct.
The only way we're going to buy cultural authority is to get steeped in the science and to share the science. Exactly what you said as it relates to the Mead study, but we need more.
And we need to be, and this is what has to be the table talk in chiropractic offices, right? It has to be, this is what the research shows. This is what the evidence suggests. This, you know what I mean? Like, we've got to start this understanding this vocabulary and how to start representing ourselves as the most evidence-based scientific profession available for people with spinal health problems, because that's what we are. But until we see ourselves as that, we're never going to portray ourselves as that. And so that's the part of this, is understanding and being an expert in what the literature says about chiropractic. And that's why I'm so adamant about it. So now we're up to 1990. In 1993, the Manga report comes out.
Ottawa.
Unbelievable. Pran Manga, University of Ottawa, probably in Canada, the one of the country's most eminent public health people, right? And so he doesn't know anything about chiropractic. But what happens in Canada is the same thing that happened in New Zealand. The Canadian Medical Association started complaining to the government that chiropractors were making a lot of money, seeing a lot of patients, and getting cultural authority. Because what happened was the usage rate in Ontario went huge for chiropractors when they started covering it. But the reason they started covering it was because there was a public demand for it, and it worked, right? People went back to work sooner on workers' compensation. They got back from car accidents quicker. We all know the story. But it offended the Canadian Medical Association. So the Ontario Medical Association, with backing from the Canadian Medical Association, lobbied the government to get chiropractic out of the public healthcare system in terms of reimbursement. Well, what happened was, word of this got out, chiropractic patients were encouraged to write in. And so the government, instead of just cutting chiropractic, decided that what they would do is they would hire an independent researcher, Pran Manga, and colleague out of the University of Ottawa, to do, at the time, the most comprehensive literature review regarding evidence for care for low back pain in the history of the world. Okay, so Pran Manga starts this thing. I've heard him speak. You probably have too, Gilles.
I have, yes.
He didn't know a thing about chiropractic. He's like, okay.
He's an epidemiologist.
Yeah, but he's unbiased. He's like, okay, I'll do a report. Well, to the great surprise and horror, right, of the Ontario Medical Association and many of the politicians who get donations from those roots and the pharmaceutical companies. What the Manga report concluded was that, without any question of a doubt, that chiropractic was the most evidence-based intervention for people with low back pain, because it was about low back pain. That's all they looked at. He
And
said not only that, but not only is it more effective, and not only is it not dangerous, but many of the medical therapies are dangerous and already proven ineffective, and they're still using them. And he added, it would save billions of dollars. This is in 1993 dollars. Billions of dollars to the healthcare system if chiropractors became the gatekeepers and people went to see chiropractors instead of going to medical doctors who then they get referred for surgery or physio or anything else that doesn't work. And so it was a shocker. That report is the reason I'm a chiropractor. I read that report in entirety before I decided to become a chiropractor. I had a very interesting personal experience. I was on a rugby scholarship, and I got very badly injured playing rugby. And so I got the best care. I got referred to the neurologist. I got, all the physio care at school. It was all part free for me as a varsity athlete. No one could help me. Finally, someone said to me, the physiotherapist actually at that University of Victoria said, you should go to a chiropractor. So I talked to the sports medicine doctor, who is also, by the way, one of the guys, one of my, he's on my panel for my thesis for my master's degree in exercise physiology. So I knew him really well. He said, do not go to a chiropractor. I was like, well, what else am I going to do? Nothing else is working. He goes, I don't know, but don't go. So I went anyway, because I was suffering, and I got better, significantly, quickly. And I went back and told this guy, and it changed my life. Because at that point, I was set to do a PhD at the University of Saskatchewan. I'd already been accepted. I was going through my thesis. Like, there was about 6 of us in the graduate class. 4 of them were going to med school. A couple of them are surgeons now. A couple of them are MDs. Like, we were all in a pretty tight sort of allopathic net. You know what I mean? And this guy did not want to hear that chiropractic helped me. And I just went, this whole thing in my life so far has been about evidence. Evidence is the only thing that matters. Evidence, evidence, evidence. And this guy did not want to know. Then I read the Manga report, didn't want to know. So I said, that's it. I'm a chiropractor. I'm going to, don't piss me off. You know what I mean? I've been pissed off since, as you know. So I just thought it didn't make any sense. And then I asked people, so just know that history a little bit. And so then what happened was, now we were winning on the cultural authority and the evidence game. So you know what medicine did? They said, we need more evidence. We need more evidence. We need more evidence. They didn't have any, but they decided that because they had cultural authority, that they could demand a higher level of evidence from chiropractic than they could meet themselves. And so what they did was they kept saying, well, we'd include you in this insurance, but you need more evidence. Well, we do this. And at the time, what was medicine offering? If you look back from in 1993, what could you get from a medical doctor for low back pain? You could get drugs, or you get a referral for surgery that didn't work and was dangerous, and failed back surgery syndrome was prevalent then as it is now, right? So since 1993, when Manga concluded that the most evidence-based intervention is chiropractic, what new things have come along in medicine? Vioxx? How'd that go?
Not well.
New cage fusion surgeries for fusion of the low back. How's that gone? Complete, utter disaster. Does not work. Right? And yet back surgery rates are going up to the point that I've now surpassed hip surgeries, even though there's no evidence of effectiveness. Right? They're terrible. Look at the data. Read, there's the Magout study. There's Carnegie from Stanford. You look at Ian Harris's book out of Australia, an orthopedic surgeon who wrote a book, says surgery, the ultimate placebo. I mean, the information on this is unequivocal. It's terrible. They got opioids. How did that go?
Oh, horrible.
They've got corticosteroid injections, zero evidence. So what exactly is it that they have to offer? If you're going to be an expert in your product and services, you also have to know what your value of your product and service is compared to what other alternatives are available for the same problem for the same client. And the truth is, chiropractic is on top. I haven't even got into the evidence for chiropractic yet, which I'm happy to talk about. But if you just understand that background a little bit, so now this constant demand, well, you need more evidence, you need more evidence. Do you know what the gold standard of care in medicine has been for decades? Paracetamol. It's been in every clinical guideline around the world for low back pain as the gold standard of care in every guideline around the world for low back pain. paracetamol or Tylenol or acetaminophen. They're all the same thing. Do you know how much evidence they've had for that? How many randomized controlled trials they had? Zero. There's a paper by Davies in 2008 that went over this and said, since this is the standard of care in every single low back guideline, maybe we should see if there's any evidence for it. And they found none. Finally, in 2017, in the Chow et al. Systematic review that was for the American College of Physicians low back guidelines, they finally said paracetamol has no effect. It was the standard of care with no evidence for 40 years. And at that time, their gold standard of care, which had zero evidence and does not work, they were sitting there demanding more evidence from chiropractic. So just put that in perspective. And I think sometimes one of the things we suffer from is an inferiority complex to all things medical. Now, there are some things medicine's way better at than us. No doubt about it. Spinal care is not one of them. It's just not even close. So, since manga, the passive physiotherapy modalities are considered guideline discordant. The special back exercises, none of them have any evidence, guideline discordant. The surgeries, virtually guideline discordant. I mean, there's nothing that they really have to offer that has any evidence, and their stuff, almost all of it is dangerous. So they try to make chiropractic say about chiropractic what? That we had no evidence and that we were dangerous. Lies. There's no evidence that we caused stroke. That was ridiculous. It was fabricated. Chiropractic bought into it hook, line, and sinker. Too many did. There's no evidence that we caused disc herniation. So first they try to prove that we are quacks. We disproved that. Inquiries, evidence. Then they realized they were losing cultural authority. They said, we've got to demand more evidence from them, even though we have none. Then they said, we're so useless, we're going to start giving heroin for low back pain. That's how bad all of our other interventions are. We're actually going to do opioids. And look what happened. And so I just think we don't ever want to have an attitude that all things medical are bad, or that any individual medical doctor we could judge without knowing that person. That's ridiculous. But we can say, as a whole, the medical approach to low back pain has been an unmitigated disaster of financial, human suffering disaster, a financial disaster, and there has been a concerted effort and a bias against chiropractic SMT. And that's reality.
And the collateral damage is huge.
It's almost, I wish they could put a little ticker up like they have for COVID-19 of all the people who have been damaged because they got bad advice about going for surgery or an injection or an opioid or Vioxx. Come on. More people have been killed because they had a low back problem that they got bad advice for than will ever die of COVID-19. It is a worldwide. First of all, the prevalence of low back pain is growing worldwide, and it's already huge. It's an enormous problem if we just talk about low back pain. And people go, well, why are you talking about low back pain? And I'll say, because that's what's in the literature. So if you're going to be evidence-based, you have to be able to talk about the evidence. Now, I'm not suggesting we don't have effects on other things. I'm very open to talk about whatever you want to, but I'm going to ask you the question, where did you read that? Where's it published? And if it's not published, it's your clinical experience, which I value, but it's not something that I can talk about in the same and categorize it as evidence-based.
So other than the MEAT study that you've quoted, and of course the New Zealand report, which I read years ago,
right?
New Zealand report was actually published the year that I graduated from chiropractic college. Wow. What are some of the studies that the students could access and read to actually raise their scientific understanding that would automatically raise their faith, constant belief, because they would have scientific certainty that what they're doing is right?
Yeah, excellent question, and a perfect place to go after that initial discussion. So I always say to chiropractors, you should be able to cite and quote at least 10 studies that show the effectiveness of chiropractic off the top of your tongue. Now that's going to take you about 10 minutes a day for a month of reading. I don't think that's too much to ask. I do a research review service, which, I always say to people, if you don't like it, I'll give you your money back. I have no problem with it, but it just helps you because not only is it listing the study, but is explaining it to you, which as someone with a graduate degree in in science with research methodology, that can be important. But studies like, you know, like just a couple, like the Cifuentes study, which basically showed that people who got chiropractic care had less use of opioids, less use of surgery, got back to work sooner, and had less relapse. Like a major retroactive study looking at all the data from insurance companies. You know, there's intervention studies
Can you
like
spell the name of that one? I don't think I've read that one. What's the name of it?
Cifuentes, Cifuentes et al. Cifuentes et al. That's 2011. You know, you look at the Schneider study in 2015 showing chiropractic care is superior to usual medical care. You look at the Bishop study in 2011 showing chiropractic care far superior to usual medical care. You look at the Von Heyman study showing chiropractic better than NSAIDs. You look at the Gertz study that just came out looking at, I think that was the military one, if I'm not mistaken. You know, there's Brantford 2014. There's all these kind of studies that if you just go start looking at the evidence for chiropractic care, there's a ton of it out there, but you just need to be aware of it. I'm not sure if there's a class. I don't know how it works at chiropractic colleges anymore, but I'm going to make this suggestion. There should be a class, or at least this should be part of one class, whatever it is, that actually goes over the evidence so that chiropractors are armed with the ability to cite evidence regarding the clinical effectiveness, cost effectiveness, and safety of chiropractic. Because there's an enormous amount of information. The Hidalgo systematic review, the best systematic review ever done, because it's the only one that differentiated between thrust manipulation, or SMT, and mobilizations. All the other them pull all that data together, so it lowers the level of evidence for SMT. It's just like, if you don't understand why these systematic reviews are so biased, you could get confused because these systematic reviews come out and say, chiropractic's okay, it's no better or worse than anything else. But those, if you actually understand how to read those things and the inherent biases in how they grade the level of evidence, and you'd be shocked. And so these are things that I go over in my research review or in my seminars that I think are really important for chiropractors to understand. Chiropractors don't need to be scientists, but they do need to understand the science, and they do need to understand this simple fact, that the level of evidence for chiropractic SMT is by far better than any other intervention available, inside or outside the scope of chiropractic. Chiropractic SMT or an adjustment. Now, the reason I call it chiropractic SMT, it's the same reason Heidi Havoc does and everyone else does, because that's what it's called in the literature. It's synonymous with adjustment, but that's the reality. And people say, well, they're not even close to the same. And I always say to people, calm down. If I videotaped 1,000 people providing a thrust input into a patient, and the sound was off, and I didn't tell you which was which, you would never know which was an SMT and which was an adjustment. What's the difference? You could say it says there's a philosophical difference, but I'm saying, well, I'm not talking a philosophical difference right now. I'm talking about, is there a difference in effectiveness in a clinical setting? And there's no evidence that calling the same thing one thing and calling the same thing another thing changes its effectiveness. So, well, no, an adjustment is aimed at a subluxation. Well, what's SMT aimed at? The exact same thing. If you actually look, one of the things that everybody in chiropractic can agree on, and this is a really important thing to understand, everybody, is that everybody agrees that the indication for an adjustment or SMT is nothing other than spinal exam findings. In other words, the legal clinical indicator, the legal requirement for you to show that there's a clinical need for a chiropractic adjustment is the same as what you need to show there's a clinical requirement for chiropractic SMT. You have to show a segmental dysfunction. So whether you want to call that subluxation or something else, I get it. And what all subluxation, well, the vertebral subluxation complex definition does is it makes everybody aware that there's changes in motion, there's changes in neurology, there's changes in inflammatory and stuff, biochemistry. So that's a really great definition of that lesion. But the fact of the matter is the clinical indicators of that lesion are the same, whether you call it a subluxation or dysfunction. That's why Heidi says they're synonymous in her papers, because we don't know how to differentiate that. So the truth is that let's not get hung up on things that maybe will be able to detract from us using the evidence. And the evidence is that in terms of interventions to restore motion, to restore proper afferent neurology, to restore proper, sensory motor cortex function and sensory motor integration patterns, to resolve inflammation and scar tissue, that chiropractic SMT or adjustment is the best intervention. And in terms of even looking at pain relief, SMT or adjustment is the best intervention available. It's better than anything else within the scope of chiropractic, and it's better than anything else outside the scope of chiropractic.
So what you just said, so I can reframe it a little bit for the students listening in, is that an adjustment has those positive effects, and there's nothing better than an actual adjustment to restore function, both orthopedically, I guess, and neurologically, because of its input and direct effect on the frontal cortex and brain function, correct?
And symptomatically. So watch. This is how I always explain it. Is that does a chiropractic adjustment affect the nervous system? 100%. So does exercise. So does immobilization. Maybe not in all the same ways, but do you understand? Saying we have an effect on something is not the same as saying that's where we have our direct effect or that's what we're an expert in. As I say, exercise changes. And exercise, I'm an exercise physiologist. Do I know that exercise improves cardiac function? But I'm not a cardiologist. I'm an expert in exercise. Chiropractors are experts in segmental spinal health. That's our expertise. That's our unique value. No one else even is taught how to properly palpate and assess segmental motion. We are experts in segmental motion. That segmental motion is a requirement for proper neurology. You can't possibly control any area of your body if that area of your body properly, you can't properly coordinate and control it if that area of the body can't move properly, because movement is required to send the information to the parts of the brain that are required to send it back out. So I always use Hilton's law, if I can just take 2 seconds. So Hilton's law says, can you see my elbow there?
Yep.
Okay. So Hilton's law says, I don't want to show up, but Hilton's law says the nerve that innervates the joint innervates all of the tissues that cross that joint. So the nerve, and this is true for the spine, it's any joint, any synovial joint. So the nerve that innervates that joint innervates all the muscles that cross that joint. It innervates the capsule, right? It innervates the ligaments and the tendons. So here's what I try to explain to people about chiropractic. You talk about this elevator talk where you got to be able to explain chiropractic. So let's just explain chiropractic in the most simple, evidence-based way that is bulletproof. And whether you're talking to an orthopedic surgeon, whether you're talking to a neurologist, whether you're talking to a lay public, they all understand it and it's irrefutable. That's how I believe we should talk about chiropractic.
And this is going to be a great piece for the students right now.
Right. So watch. If I can't move that joint, even if I could just move it to here, but I can't move it to here. If I can't move that joint through range of motion, what do I absolutely know happens? First, let's just go in the periphery, because some people like to focus on the periphery, which is absurd when you talk about pain, because pain's a central phenomenon. So it's just so neurologically ignorant to say, well, I only deal with like peripheral inflammation and I'm focused on pain. I don't talk about the nervous system or anything to do with the brain. I'm like, well, there is no pain without the brain, silly. Like,
exactly. But anyway. The brain is what interprets pain.
Correct. Interprets nociception. So watch. If I can't move that joint through full range of motion, what do I know happens? Within days, I know I'm going to start to get scar tissue adhesions. I know that the size of those scar tissue adhesions, right, are going to get bigger with more time not moving through full range of motion. I know the tendons are going to get scar tissue and they're going to get weaker. The muscles are going to get weaker, correct? All these things true? And I'm going to start to get inflammation in that joint just from lack of movement. I also know what's going to happen is I'm going to change the input from that particular joint to my brain. There's a part of my sensory motor cortex which is specifically related to that area of my body. Correct?
Yes, sir.
So now that sensory motor cortex, the synapses in that sensory motor cortex are actually going to start to go away. Right? I will lose synapses. I will lose my ability to know where this part of my body is in space. And I will lose the ability to control the muscles that cross that joint. So I will lose strength and coordination. This has been proven without a shadow of a doubt in the literature, by the way, not the chiropractic literature, but there's all kinds of information.
Yeah, because if you don't use it, you lose it.
Correct. It's very simple. So if I can't move that joint, by the way, every joint in terms of the neuromusculoskeletal system, if you do not move a joint through full range of motion against resistance every day, it's dying. It's degenerating, right? And so is the part of the brain that controls it. I'm not even going to get into where the nociception goes, but that area is now inflamed, so it's sending nociception, which is going to go into the hypothalamic pituitary adrenal axis and increase cortisol. It's going to affect my amygdala because it's seen as a physical stressor. Now we can get into all kinds of other stuff, but just understand nociception could go there without ever being pain. It's affecting all kinds of things and causing a stress response. It also inhibits muscle contraction, nociception, and that's the inflammation. But I also lose proprioception. So now I lose the ability to control that limb, to know where it is in space. The muscles can't get fed properly by being recruited properly. So that area of my body literally starts to degenerate. There's no doubt about it. And so does the part of my brain that controls it. So now I ask you this question. First of all, is it common not to move our spinal joints through full range of motion every day?
Absolutely.
In industrial society.
Common.
It's pandemic. Most people, the British Chiropractic Association years ago did a study, and the average person now sits for, I think it's 32 years of their life, like 11 hours a day or something ridiculous. Okay. So when you don't move your spine through full range of motion, what happens? Exactly what I'm describing. Scar tissue, inflammation, all this stuff, any joint, but the spine in particular, because we can't move our spine the same way we can try to restore motion to our elbow, right? That's why you need chiropractic care. But watch, here's the question, students. Just think about this for a second. So that joint cannot move through full range of motion. It has scar tissue, it's inflamed. It's not sending the right signals to the brain or getting the right signals back because the sensory motor cortex is losing synapses. So let me ask you this question. Will surgery fix that? Will fusion surgery fix that?
Absolutely not.
Will a drug fix it?
Absolutely not.
Painkiller, laser, ultrasound, some kind of soft tissue therapy.
Nothing but an adjustment. Nothing.
The only thing that can fix that lack of motion is to restore motion. But when we restore motion, what do? We break up scar tissue. We start to resolve inflammation. We reduce nociception. We start to reestablish the proprioceptive connection. We change and increase the synapses in the sensory motor cortex. Very clear information on this in the literature. So by restoring motion, do we affect all these things? Yes, 100%. But what's our focus? What tells us whether someone needs an adjustment? Not a brain scan, not a scan of their, not a scan of their sensory motor cortex. Not pain, not inflammation. Can they move? And clearly, you put up your hand. We now know also, if you look at the literature on palpation, motion palpation is actually quite reliable, not only intra, but inter-examiner, if you set a few parameters, which they've done in the literature. So it can be quite reliable. And so and especially if you talk to the patient and say, is that area tender and restricted, allodynia and restriction. So now, just think about it. If of all the things available, what's the only thing that can restore motion in that joint? An adjustment. Right. And it's just now in the elbow, you might be able to go and slowly through time, go through and kind of get range of motion back to that. That's actually probably more possible in the elbow than it is in the spine. You can't do that in the spine. There's just no way you can do it. But also firing that thing quickly also sends different neurological signals. Heidi's work looks at this quite well. So does other people. So that rapid thrust is also really important to reestablish those pathways and also to break up that scar tissue. So if you've got a problem in your spine and it's not moving properly, what intervention can you get? And here's the deal. If there's one thing that we're suffering from, if you look at the patterns of the increased prevalence of back pain, and by the way, folks, listen for a second. Anybody who tries to tell you that low back pain is self-limiting is a moron. They're just ignorant of just listen to me. If acute low back pain was self-limiting, we wouldn't have a pandemic of chronic low back pain, because you have to go through acute low back pain to get to chronic low back pain. It just doesn't make any sense. Further, chronic low back pain prevalence is increasing. How would that be possible if acute low back pain is self-limiting? If you actually look at the research by is the best one, the European Spine Journal, article, and I think that was I can't remember what year that was, but anyway, in the late 1998, where actually they said all of these guidelines around the world that try to state that low back pain is self-limiting. Do you know what that was based on? It wasn't based on the fact that people were better. It was based on the fact that they stopped going to the medical doctor because it wasn't working. But anyone who stopped getting care, they ticked off as resolved.
Oh,
The
right.
data was absolutely ridiculous. There's no evidence anywhere that low back pain is self-limiting. In fact, there's a lot of evidence to say that if you don't take care of it properly, it turns into chronic low back pain. And so what's the best thing that we can do, right, is to provide a proper amount of care. So if chiropractors would understand, there's a great study by Senna and Macaulay, and that study was in 2000, and I wrote it down, 2011. I usually remember.
So maybe we can close with that because we only have a couple minutes left.
Sure.
Dr.
So
James.
Senna and Macaulay did a really interesting study, and what they did was they said we're going to have three groups. Two groups where they get chiropractic manipulation, or it wasn't chiropractic manipulation, it was a medical doctor doing it, but they got manipulation of the low back 3 times a week for 4 weeks. Two groups, same. And the third group got fake manipulation or a placebo 3 times a week for 4 weeks, 12 visits. At the end of those 12 visits, the two groups that got manipulated 3 times a week, real manipulation, were significantly better on scores of, visual analog scale for pain. I think they used the Roland Morris, activities of daily living functional questionnaire, and they also used quality of life. The placebo, no change. So that showed that active manipulation was better than placebo. A lot of people go, oh, there's no evidence that we're better than placebo. Yes, there is. There's several studies. But here's what's interesting. Here's what they did. What they did was, and this is really important in terms of acute pain turning into chronic, is they decided that they were going to take one group and continue to adjust or manipulate those people, and that's the term in the study, manipulate them every 2 weeks for the rest of the year. But the other group, they didn't touch. So what happened was both of these groups that got manipulated 3 times a week for 4 weeks, they both had excellent results, right? But then the one group, they just kept going. And the group that kept going, not only did they retain all the benefits that they had from the original care, they actually continued to improve throughout the year. The group that stopped getting care after 12 visits, not only did they not improve throughout the rest of the year, they actually returned to almost baseline. They had wasted their money. And if you look at most chiropractic studies, in fact, not the chiropractic ones, but some even of the chiropractic ones, inexplicably, but also manipulation studies done by other people, they rarely even give us 12 visits. And they never give us any maintenance care. They never give us care in the period between where they stop the study, and very often they'll stop the study after 2 or 3 chiropractic. By the way, this is very common in the literature. They'll give 2 or 3 manipulations, in the first couple of weeks, and then they'll evaluate them a year later and say chiropractic had no effect.
Crazy. So closing words of wisdom for our students, Dr. James.
Closing words are, listen, be an expert in your product and service, and the more expertise and the more that you read and understand about the evidence for chiropractic SMT, the less you will move away from that in your clinical practice, the less you'll be intimidated by any other practitioner, the more confidence and certainty you'll have in your product, and the more that you apply that properly in practice, the better results you'll get. There's absolutely no doubt that as you move away from the adjustment, you move away from evidence and effectiveness in your clinic. Now, you're going to be tempted by it because there's all kinds of people that things are socially accepted. That's not evidence-based. All these other sort of things that you can, adjunctive sort of things that you can do. But listen to me carefully. I promise you, and I'm happy to be challenged on this in public, there is nothing that comes close to the level of evidence. So what I say is, and I've talked to Jill about this, is I'm moving away from the concept of being subluxation-based or subluxation-centric and saying, let's be adjustment-centric. Because what adjustment-centric does is it makes us all the same. Now, subluxation, I get it. I understand all the parts of that, and I'm not diminishing it in any way. All I'm saying is, if we want to pull everyone together and we want to really be evidence-based, it's hard to be evidence-based and cite some studies that have shown people can reliably find and improve a subluxation. You won't find one. I'm sorry, but you won't. But it's easy to say that we can find studies that show that when people find a lesion looking at restriction and tenderness, again, look at Heidi's work, same thing, and then they adjust that they get results. And the adjustment, or SMT, is the thing that's most evidence-based, and it's something we can all unite around. But if anyone tries to convince you to move away, or somehow that you're not as good of a doctor, or you're not as scientific because you focus on the adjustment, that person is poorly read, or they're deliberately misleading you because they're trying to sell you something else. But these are the most evidence-based intervention, or an instrument that can do it as well, that you'll ever have in practice, and they're going to get you the best results.
Well, James, thanks for taking this hour with us. I know that the students who will listen in will get tons of benefits, and I think they'll look forward to actually meeting you on campus. So when all this craziness is over, let's figure out a way to get you to come and spend the weekend with us, continue to inspire students, doctors, and hopefully we're going to be able to host a great Dr. James Chestnut seminar here at Lead University.
Thank you. Thank you.
Thanks for joining us.